Oh, thank you, Rico. Happy Friday, everybody.
Good,
Hope
Dr.
you're
Mark.
having a hope you're having a great week, and hope you're ready for this holiday weekend and you're spending time with your family and eating good food and staying warm. So I'm really excited to talk about the article that I have to present today. But before I do that, I want to read from the Controlled Dangerous Substance Act what the definition of a Schedule 1 controlled substance is, just to remind everybody. Schedule 1 controlled substances are substances that have no currently accepted medical use in the United States, a lack of accepted safety for use under medical supervision, and a high potential for abuse. So that is the definition of a Schedule 1 drug. My story today comes from NORML, and it's titled, Scientists Have Published Over 30,000 Papers About Cannabis in the Past Decade. For a third consecutive year, researchers worldwide published over 4,000 scientific papers specific to cannabis and its constituents and their effects, according to the results of a keyword search of the National Library of Medicine, pubmed.gov, if you want to go to the website. Despite claims by some that marijuana has yet to be the subject of adequate scientific scrutiny, scientists interested in studying cannabis has increased exponentially in recent years as our understanding of the plant and its active constituents, their mechanism of action, and their effects on both user and upon society. NORML's deputy director, Paul Armentano, said, "It is time for politicians and for others to stop assessing cannabis through the lens of what we do not know, and instead start engaging in evidence-based discussions about marijuana and marijuana reform policies that are indicative of all that we do know." All that we do know. Wow, what an amazing concept. Over the past decade, there has been a dramatic increase in scientific inquiries about the cannabis plant, with researchers publishing more than 32,000 scientific papers. A couple of those were mine, folks. About cannabis since the beginning of 2013. Much of this uptick of result of researchers are newfound focus on marijuana's therapeutic activities, as well as investigation into real-world effects of the legalization laws. In all, more than 70% of all peer-reviewed scientific papers about marijuana have been published in the past 10 years. That's an amazing statistic. 70% of all papers have been published in the last 10 years. That is amazing. And 90% of this literature has been published since 2002. As of writing, PubMed.gov cites over 45,900 scientific papers on marijuana dating back to 1840. 1840 they were writing about this, okay? Available to the public online since 1996, since PubMed is a free resource supporting the search and retrieval of biomedical information about life sciences literature. Summaries over 450 studies of safety and therapeutic efficacy of cannabinoids in different patient populations are available from NORML. And folks, when you go to the NORML site and you click on that link, it leads you to a new web page that describes all of the medical conditions to which there is medical evidence in the peer-reviewed scientific literature that cannabis is effective on. Let me read this list of diseases. It's very impressive. Alzheimer's disease, ALS, autism spectrum disorder, chronic pain, diabetes, epilepsy, fibromyalgia, gastrointestinal disorders, gliomas, which include cancers, hepatitis C, human immune deficiency virus, otherwise known as HIV, Huntington disease, hypertension, inconsistence, I don't know what that is, but it must be a disease. Insomnia, methicillin-resistant Staph aureus infection, so antibacterials. Migraine, multiple sclerosis, Parkinson's disease, post-traumatic stress syndrome, pruritus, rheumatoid arthritis, sleep apnea, and Tourette syndrome. We also know that, cannabis is effective at certain classifications of epilepsy where anti-epileptic drugs don't work at all. The drugs that have been developed have no efficacy whatsoever, and the only thing that works in these intractable forms of epilepsy is CBD. So I see that glaucoma is not listed here, but we all know that cannabis certainly has both shown clinical efficacy in humans with glaucoma. So when
one of the what one of the federal patients is diagnosed with to
that's correct. Yeah,
one of only
that's
two
correct.
left living. So I don't understand why that's not on the.
That's correct. And that Dale is very good to point that out. That's actually a medical prescription for cannabis to treat that. So I just wanted to say that, we do have medical evidence to support. Let's go back to our Schedule 1 definition again. Schedule 1 definition basically says that there is no known medical use. Well, if you pull up NIDA's budget for 2023, you'll see that they spend $1.8 billion. That's their budget. And a big fraction of that budget is spent on the negative aspects of cannabis. And if you go to NIH.gov and you search who's being funded, the government spends billions of dollars still to prove that cannabis is deleterious to human people who use it and people who consume it. While the scientific literature shows all of this efficacy and shows documented medical use that's in the peer-reviewed literature. And in peer-reviewed literature, they don't give a shit about drug policy. They just know that the data shows that this works. And that's what we need to get out there. We need to unwind the Schedule 1 listing of cannabis. It is an absolute crime against humanity that cannabis is Schedule 1 when all of these medical uses are known and documented in the scientific literature. That's my story for today. I want to wish everybody a Merry Christmas, Happy Kwanzaa, Happy New Year. Let's do it better in 2024, and I'll be interested in what my fellow correspondents have to say. Thank you. Dr. Mark from the shores of Lake Champlain here in Vermont.
Thank you, Dr. Mark. Once upon a time, we were all saying, yeah, we need more science, we need more papers, we need more publishing. At what point?
Yeah. Dr. T, what do you think about this?
Will we be able to say we have enough?
Is this enough? Is this enough?
Well,
is this enough research?
There's more on most drugs that we currently prescribe every day.
Yeah.
Of all the drugs we commonly consume, there are more studies on cannabis than aspirin. What?
Mm-hmm.
Yeah, I always bring it back to Alzheimer's because I've lost a couple of relatives to Alzheimer's, and there are like 5 FDA approved drugs, and none of them have any proof of working. 0 proof of working.
Mm-hmm.
But they're FDA approved.
Yeah, I mean the medical community will never say there's enough research. We always want to do more research. It's really the political legal community that's ignoring the evidence, and they're the ones that will need to reverse. There's certainly enough compared to other substances out there. As we're pointing out, we've done a lot more research on cannabis than many other substances that are acceptable. So, the other problem is the idea of the plant versus the pill. It's difficult for the FDA to regulate plants. They just don't have a hard time with it. And so
Well,
that's sort of another underlying
Dr.
problem.
T, can I ask you a question? So in that definition in the Controlled Dangerous Substance Act, they use the word accepted, no accepted use. So when you see these papers and they're publishing, preclinical data in mice, I get it. But when you see clinical data that actually is convincing on human population, when does a use become accepted? Only after it's FDA approved and gone through clinical trials? Is that an accepted use? So is that
Correct.
what we're hung up? Okay.
Correct.
Is that is accepted a defined definition that is that in order to have
all are bullshit because we have Marinol, Dronabinol, we have Schedule 3 with Epidiolex, we have Schedule 3 with there's another one that's slipping my brain right now.
Right, Nabilone. So the fact that those made it over the FDA goal line, doesn't that mean that the plant from which they were derived is also known medical accepted use? Maybe what they say is, well, it's not accepted use in the plant form, but if you get it in a little capsule that's prescribed at $300 a pill, paid for by drug insurance, bought at a drug store from a guy who dispenses drugs all day, then it's okay, I guess, right?
Well, what's funny is it's the other constituents of the plant that they're saying is the problem, because the one thing that's the Schedule 1, they're actually identifying for medical use. And it's the cognitive dissonance that is going on right now is staggering. And I just want to remind everyone that years ago, Congress passed a law requiring the ONDCP, the Office of National Drug Control Policy, to, by any means necessary, prevent the legalization of cannabis while they spend billions figuring all this out. And I'm just asking that we can walk and chew gum at the same time here, and take the fangs out of the DEA and this policy. This is why rescheduling is not the answer, because this conundrum will only get worse and more confused. We have a natural plant that should be legal for all Americans to grow, and we should continue research, absolutely, for pharmaceuticalization, medicalization, being able for a doctor or a nurse to help patients in hospice, in hospital, with known things that will help those symptoms. This is insanity, and we just need to really approach them differently. Come on, America. We can walk and chew gum at the same time.
Common sense approach. Well said, Dale.
Yep. And